Welcome all. We continue with our clinical governance module, and today's topic for the discussion is a obtaining the valid consent. Okay, so this is the clinical governance advice number 6, published in January 2015. Okay, so we'll discuss about how to approach the consent. The basic or the core principle of the consent is that it is a process of shared understanding and shared decision making. So while taking the consent, it should be informed, it should be voluntary, and it should be given by the patient who has got a capacity. Okay, so mental capacity is very, very important. So it should be informed, voluntary, and it should be given by a patient with the capacity. Okay, so these are the points which are very important when we discuss about the consent. Okay, so what are the essential components of the informed consent? Okay, so it is the when we discuss about the consent, there are certain things which are very important. Like, before taking the consent, we need to ensure that the patient understand following things. So which are the things? One is disease related or the diagnosis. Second, information which is related to the treatment. Third, what are the alternative treatment? And fourth will be what are the uncertain areas, because sometimes even if you give the proper treatment, there are certain uncertain or gray areas that we need to discuss. So first is a diagnosis, second is a treatment, third is alternative, and fourth is a gray areas. So in the diagnosis, nature of the condition, prognosis, what are the likely consequences. Then treatment related information will, what is the proposed treatment and intervention which we are planning. It may be conservative, it may be medical, it may be surgical. And what are the benefits of that? What are the risks and complications of this particular approach? And even if the patient does not undergo, what is the risk? Okay, that we need to tell. Then after that, it will come, what are the alternative options, whatever is proposed, but apart from that proposed treatment, what are the alternatives which are available? So reasonable and accepted alternatives we need to discuss, including the conservative options, and uncertainty, that certain gray areas, if they are there, or the unclear outcomes, that also we need to discuss. Another important thing is the standard risk terminology. Again, here SBA, they are asking. Okay, so here when we are describing the risk to the patient, we should generally, the term which is written in the consent form will be very common, but while talking, we have to use the numerical as well as the verbal explanation of that. That means layman's equivalent we need to use. Okay, so numerical should be supported along with the layman equivalent. Okay, so the term which is very common will correspond to 1 in 1 to 1 in 10 risk. Okay, and that is equivalent to the person in the family. Then what does common mean? Common is 1 in 10 to 1 in 100, that is the person in the street. Uncommon is 1 in 100 to 1 in 1000, that is the person in the village. Rare is 1 in 1000 to up to 1 in 10,000, that is the person in the small town. And very rare is less than 1 is to 10,000, that is the person in the large town. Okay, now here just remember, very common, common, uncommon, rare, and very rare. And this uncommon corresponds with the person in the village. Okay, so village, small village generally has got a population of 1000. Okay, then after village comes a small town, then comes the large town. And below this will be the person in the street and person in the family. So person in the family, around 1 in 10 up to 1 in 10, that is very, very common. The common 1 in 10 to 1 in 100, that is the person in the street. Uncommon 1 in 100 to 1 in 1000, person in the village. Rare 1 in 1000 to 1 in 10,000, that is the person in small town. Very rare is less than 1 is to 10,000, that is the person in the large town. What happens when they give you the figure? And here there is a little confusion, because at both places this is 1 in 10 is coming here, also 1 in 10 is coming, 1 in 100 is coming here, 1 in 100 is coming here. So if they, and generally they ask you these borderline things, they may ask you 1 in 10,000. Okay, so where it will come? So that is the situation. But generally this upper thing should be excluded from this. So if you are asked about 1 in 10, it should be common. If you are asked about 1 in 100, it should be uncommon. Okay, because both the things cannot be included in use numerical plus verbal explanation and tailor to patient understanding. Okay, so some patients understanding may be different, we may have to use the visual aids also. So there are certain practical aspects that when the consent should be taken, it should not be taken when we are examining the patient. It should be taken. It should be taken before we start our examination. Okay, and we should ensure privacy, adequate time, non-stressful setting. Respect and communication, maintain the dignity and courtesy, avoid patronizing the terms. Okay, so doctor-patient relationship is based on the confidentiality. Good practice is to see the woman alone at some stage. Okay, so whenever there is a consultation, always give some time to the woman when she is alone, or have a consultation along with that particular lady, because there are certain issues like maybe domestic violence or abuse. They may not be able to disclose if there is an attendant. Okay, so support person is allowed if the patient wishes, but we have to be cautious of the coercion and abuse. Okay, so special situations such as female doctor preference. If the patient asks for female doctor preference, respect the patient choice. Reason, it may be cultural or religious, and it may be because of the previous trauma also. There may be language barrier. So for that particular case, we have to use the approved interpreter services or the professional interpreters we use. We always avoid family members because there is a possibility of the bias risk. Okay, and provide translated written information. When we are providing the information leaflet, we can provide that in a multilingual information leaflets are available. Now coming to the capacity and age, this is also very important. So in adults, that is the age more than or equal to 18 years, we presume that there is a mental capacity to think and give the consent. Okay, so unless proven otherwise, 18 or above, there is a presumed capacity. Now, if the child below 16 years of age, consent will be given by the parent or the guardian. But we have to encourage the involvement of the child also. Okay, so below 16, it is the parent or the guardian involvement is there. Then Gillick competence. If the child is below 16 but can consent if there is a sufficient maturity and understands the treatment. Okay, so Gillick and Fraser competence, below 16 the child can consent if there is a sufficient maturity and understands the treatment. Okay, when there is an issue comes about the termination of the pregnancy, then it is the Gillick competence which is taken into account. Okay, now when you are given the scenario, please read what exactly the scenario is about, whether it is about the termination of pregnancy or whether it is about the contraception. If it is related to the termination of pregnancy, you will pick the Gillick competence. Okay. If it is about the contraception, you will, because there are Fraser guidelines for the contraception, then your answer will be about the Fraser competence. I hope you are getting this. So below 16 years, the child can consent if there is a sufficient maturity and understands the treatment. So above 18 years, always presume the capacity. Between 16 and 18 years, presumed capacity similar to the adults is there. Below 16, a parent will give the consent. It is huge need, but however, child can give if it is a Gillick competent. So below 16 years, parental consent usually needed, but if the child is Gillick competent, then child can also give, and Gillick competent child can consent independently. Okay, so here normally below 16 years, parental consent usually needed, but if it is a Gillick competent, this will come along with the termination mainly. Okay, then the consent the child can, and it will be scenario related to the termination of pregnancy mainly below 16. Okay, then refusal of treatment, not absolute in minors. It can be overridden by the parents or the courts. Now, between 16 and 17 years, child can or the adolescent can give the consent, but refusal may be overridden. Okay, between 16 and 17, they can consent, but refusal may be overridden. Okay. As far as Scottish law is concerned, the consent as well as refusal is above 16 years. So in UK law, it is 18 years, but the Scottish law, it is 16 or above. Okay. Then there are certain organizational issues. When we are taking the consent, normally what happens, the patient is explained the things in the OPD settings and the patient is admitted. Once the patient is admitted, generally previously it was like a patient used to get admitted a day prior. Then evening, again, there used to be pre-operative assessment and there used to be counseling and the consenting again. Okay. And next day the patient used to, but nowadays with early recovery guidelines, what is happening? We are admitting the patient on the same day. So the cooling off period which is given you provide the information, but after providing the information, patient has to think. So that period is called as a cooling period. Okay, so this period when we are admitting the patient, so we are seeing the patient in the OPD and directly admitted on the day of surgery because of the these newer policies of the ERA's guidelines. So same day admission and surgery, that reduces the cooling off period. So this is a little challenge, but it doesn't mean that we don't have to give the information. We have to give adequate information in the OPD setting also. Okay. Then key principle, consent must not be rushed, and first time discussion just before the surgery is to be avoided. Okay. So this is this we need to tackle here by giving the information before even in the OP setting itself. Okay, so prior discussion in the clinic or the preoperative assessment is must. Okay, so if the patient is unsure about whether to proceed or not, then defer and postpone the procedure. Okay, provide information packs and the consent forms in advance. So what are the different types of consent form? For adults who is more than 18 years, who is supposed to have the presumed capacity, use form number 1. So adult with capacity undergoing procedure, we will use form number 1. So there are total 4 forms. Form 1 used to obtain a consent from an adult patient who has got a capacity for a procedure or treatment. Form number 2 used to obtain a consent from a parent or legal guardian for a child or a young person. Okay. Form number 3 used when an adult patient lacks the capacity with the clinician making a decision in the patient's best interest. Okay. Form number 4 used when an adult patient with the capacity refuses a recommended procedure or the treatment. Okay. So form number 1 is very easy, commonly used for adult. Form number 2 is parental consent. Okay. Or legal guardian in cases of the child or the young person. Then form number 3 is for adult patient who lacks the capacity and with the clinician making a decision in the patient's best interest. So when the doctors are making the decision on behalf of the patient in the best interest, we use form 3. Okay, form 4 is used when an adult patient who has got a capacity and is refusing the treatment, then we'll use a form 4. Okay, there are certain standard forms which are there, national consent forms are there, but local modification can be done, but the core elements must be written. Okay, so RCOG forms, procedure specific consent forms are available. They are limited, but still they are improving, working on it. Then what is the scope of the consent? The main important thing is that we should not go beyond this particular document. So do not exceed the consent scope. So whatever is mentioned in the consent, that should be executed. Okay, in the operative. Okay, exception is that when the situation is emergency or life saving, example like a hysterectomy for PPH. Okay, so in that particular case, even if there is no consent, we can proceed. Okay, and then we have to document it and we have to explain it later on. So pre-consent should include possible additional procedure. Okay, and we need to document what the patient is accepting and what the patient is refusing. Then if there is any intraoperative uncertainty, if there is an unexpected finding, always seek the senior's opinion and avoid unauthorized procedures. Okay, if there is an abnormality, if it is not consented, seek the senior's opinion. Okay, and no unauthorized procedure should be performed. Now we have certain gynecological procedures. So consent in certain gynecological procedures, what are the scenarios? Okay, so the procedure, we need to justify the procedure. It may be screening or it may be diagnostic procedure, but avoid unnecessary examination. For pelvic examination, chaperone is mandatory, and always document the presence of the chaperone in the notes. Okay. Second, verbal consent in presence of chaperone is must, and we have to record in the notes. Sometimes the patient may decline the chaperone. Then what we have to do? We have to offer alternative that the chaperone will be available nearby within the earshot, and document refusal by the patient and the arrangement which we have done. Okay, so the chaperone will not be present there, but it will be nearby within earshot. Then type of examination, specify whether what we are going to do. We are going to do vaginal examination, rectal examination, or both the examination, and consent has to be very specific. Okay. Then communication, it is essential for intimate examination. Professional and sensitive approach should be there. Breast examination is not routine, so only if clinically indicated, but consent is must. Okay. Then unexpected pathologies. Okay. sometimes they can ask you the question on unexpected pathology. Suppose if there is a minor findings like endometriosis, adhesions, we are performing a diagnostic laparoscopy say for tubal patency, and there is a superficial endometriotic spots, or if there is a adhesions, it can be treated if it is been pre-operatively consented. Okay, and pre-operative discussion is essential. So when we are taking the consent at that time only, though the procedure is a diagnostic laparoscopy, a very minor finding, if at all we find the endometriotic spots or simple adhesions, we may consider the excision of those adhesions, okay, or releasing of those adhesions. That type of discussion should be there, and the patient should consent for that. Okay, then we can carry out. Then if there is no prior consent, do not proceed. Okay, so such kind of SBS can also be asked. Then if there is a surgical complication, if it is a life saving, then we have to proceed, and we will explain it later. And major additional procedure, okay, so it is to be avoided unless it is an emergency. It may need second surgery also. Okay, so even if it requires a second surgery, we should not go ahead with that particular procedure. It is a major additional procedure. Okay, then oophorectomy during the hysterectomy. It is always a pre-operative discussion which is must. Then a possibility of the oophorectomy we have to discuss in the preoperative period. Without consent, it should never be done. And if it is done, we have to document the reason and inform the patient as early as possible. Okay. We have few SBS pertaining to this and EMQs also. So, doctor, simultaneously, along with the theory, we have few questions. Okay, you want to try this? EMQ is there.
Let us see.
Yeah.
A 45-year-old woman undergoes a total abdominal hysterectomy for symptomatic fibroids. Preoperative consent included hysterectomy only. Ovarian conservative was planned. During surgery, one ovary appears abnormal and enlarged, although there is no immediate life-threatening surgery. What is the single most appropriate management principles? Can I see the options now?
Yes. Yeah.
Not the complete ones. I can see only up to H, not below that.
This is a reminder. Priyadarshini, revise your today's study.
First three. Ovary has not been removed in this case.
No, not yet. Not yet removed. What does the scenario say?
Scenario says there are only fibroids which were symptomatic and pre-operative consent for hysterectomy was only taken. Ovarian conservation was planned.
One ovary is abnormal and enlarged.
One ovary was abnormal, but there is no immediate life-threatening surgery.
Yeah.
So I think we should go ahead with the hysterectomy only.
So
Do as consented means.
Do as consented. Okay, but sometimes you may not have the same option. Okay, the option will be similar to this. Okay, so here remove ovaries only if previously discussed and consented, unless emergency or life-threatening situation exists.
C okay? Should be the correct answer.
Correct answer. Okay.
Do as consented.
Yes. Yeah. So remove ovaries only if previously discussed and consented, unless emergency life-threatening situation. Oophorectomy is a separate procedure with major consequences such as surgical menopause, infertility, long-term hormonal effects. Therefore, possibility of oophorectomy should ideally be discussed pre-operatively. Specific informed consent should be obtained. Without consent, oophorectomy should generally not be performed unless immediately necessary to save the life or prevent serious harm. If ovaries are removed unexpectedly, reasons must be clearly documented and patient should be informed as soon as possible post-operatively. Okay.
Yes.
Then non-gynecological mass. Suppose you come across in the operative a non-gynecological mass, do not operate, okay, unless proper specialist evaluation is done and consent is obtained. Okay, so this was most of the time is an unexpected finding which comes up as a non-gynecological mass which we have opened. Okay, so what you will do, specialist opinion you can take. Okay, and only with the consent it will be operated, but it will require another sitting, not in the same sitting. Okay, so for that also we have one question. Can you
Unless
read?
life threatening, one should
Yeah,
one should
withhold.
not touch it, and
Yes.
it can be done later on at a
Yeah.
different setting.
Yeah. So
A 46-year-old woman undergoes laparoscopy for a presumed ovarian cyst identified on ultrasound. She was consented for laparoscopic ovarian cystectomy. Now, during surgery, both ovaries appear normal, but a large mass arising from a sigmoid colon is identified. The appearance is suspicious for colorectal malignancy. What is the single most appropriate management principle?
okay, options.
What's the option?
Yeah, yeah. These are the options A to J.
What about the D, sir? Seek appropriate specialist involvement before undertaking additional non-emergency procedures.
Yes. So we'll seek the appropriate specialist
D
involvement
should be
before.
the answer.
Yeah, D. So seek appropriate specialist involvement before undertaking additional non-emergency procedure. Okay.
Yes.
So before surgery, as far as pregnancy is concerned, accidental
Yes.
pregnancy diagnosis or unexpected pregnancy. So before surgery, always exclude the pregnancy. Viable intrauterine pregnancy, if it is found, do not terminate without the legal consent. Okay. Then pregnancy discovered before elective hysterectomy, we will reschedule the surgery. Okay. And ruptured ectopic pregnancy, it is a life-saving condition. So whatever is a necessary, maybe a salpingectomy, if it is a life-saving, we will be doing. Okay, life-saving presumed consent applies. Okay,
Yes.
so on this we have again some question on this. Yeah, go ahead.
A 38-year-old woman is listed for elective laparoscopic ovarian cystectomy. During pre-operative assessment, it is noted that no pregnancy test has been performed. What is the most single appropriate action?
She
Let
is
us see
posted
the
for
option.
laparoscopic ovarian cystectomy. Okay,
He is posted for surgery, but no pregnancy test was done. E should be there, exclude
yeah,
pregnancy
always
before.
exclude pregnancy before planned gynecological surgery. Okay,
Yes,
any
yes,
planned gynecological, always exclude the pregnancy.
yes,
Okay.
sir.
So before elective gynecological surgery, pregnancy should always be excluded in women of reproductive age. This is an essential safety and consent principle, prevents inadvertent fetal harm or inappropriate surgery. Another scenario.
A 44-year-old woman is scheduled for elective hysterectomy for symptomatic fibroids. After induction of anesthesia, a preoperative urine pregnancy test results return positive. Ultrasound confirms a viable intrauterine pregnancy. What is the most single appropriate management? So
So
she is
here
for
is
hysterectomy,
scheduled, yeah, scheduled
but
for,
during
and she is being
anesthesia
induced, and the patient is induced
induced. She is already under anesthesia.
under anesthesia. Okay.
And
What we
urine
will.
test is positive.
Hmm.
Continue surgery because anesthesia has already started.
No, we should not
No,
operate.
we cannot do that. Reschedule elective surgery and discuss
Yes, reschedule elective surgery and discuss findings with the
with the
patient.
patient. Yes.
Yeah, we will reschedule the surgery. Okay.
Mm.
reschedule elective surgery and discuss findings with the patient. Okay,
Hmm.
a viable pregnancy cannot be terminated without specific informed consent. Appropriate, because it is a legal procedure. The termination itself is a legal procedure. Okay,
Yeah.
hysterectomy will only involve the consent. It is a treatment part, but termination is a legal procedure, so that cannot be performed. That has to follow its own regulations. Okay.
Hmm.
So therefore, elective hysterectomy should be postponed. Patient must be informed and counseled after the recovery. Next.
A 30-year-old woman undergoes emergency laparoscopy for severe abdominal pain and hemodynamic instability. Intraoperatively, a ruptured tubal ectopic pregnancy with active intra-abdominal bleeding is identified. What is the single most appropriate management?
Yeah.
So,
So she was taken for emergency
so
laparoscopy for instability, hemodynamic instability, and we
towards
found that it is the ectopic which
ectopic.
is
Hmm.
bleeding. So what we will do?
I think in this case, we have to remove the ectopic pregnancy under presumed life-saving consent.
Yes, yes. Okay, so it is a life-saving condition, so we have to remove the tube. Okay, so that is the scenario
But
for
this is such
this.
a nice arrangement that once you take the theory and then we do the SBAs or
Yeah, yeah.
EMQs,
Oh,
it is
that
a
is,
good approach.
yeah. So now if we are dealing with infertility, we have to follow Human Fertilization and Embryology Act. This act, please remember, there is an act, Human Fertilization and Embryology Act, related to the infertility. Okay,
Mm.
so whatever is specific pertaining to that act, the specific consent is required. So for sterilization, now if it is a patient wants the sterilization, it is a
Mm.
permanent procedure, so needs
Mm.
careful counseling. If there
Mm.
is a doubt about the capacity, always seek legal input, and law reference is a mental capacity act. So with respect to the mental capacity act only, we will take the consent. Now if there are certain outpatient procedures, it is always better to have the written consent, but if it is a minor procedure, verbal consent is acceptable if it is documented. So even if the consent is taken verbally, we have to document that the verbal consent is taken. Key
Mm.
principle is that patient can withdraw the consent anytime. Okay. So here, say for example, we are just doing the speculum examination and the pap smear.
Mm.
The type of consent verbal is more than sufficient because it is a low risk patient, a low risk procedure. So verbal is acceptable. However, we have to record the verbal consent. Okay. And it is just a routine cervical screening in the OPD. Okay. But if we are taking the endometrial biopsy with the pipette, then we have to take the written consent. The indication will be AUB evaluation in the clinic, and we have, there are certain risks like the pain, bleeding, that we need to document, and it has got a moderate risk. Here it has got a low risk, while it is moderate risk, so written is safer. Okay, so pap smear you can go for verbal, but endometrial biopsy you go for written. If it is a office hysteroscopy, though it is a daycare procedure, go for written consent. Okay, so indication will be abnormal pap smear follow-up, etc., and complication like a bleeding, infection risk should be documented, and it is a standard, there is a standard pro forma itself for this colposcopy and biopsy consent. Okay, for IUCD removal and insertion, again it is a written consent. Okay, it will be done in the contraception clinic. Failure or perforation risk should be explained. Vulval biopsy, again written consent because it is an invasive procedure, and suspicious lesion will be indication. Pain, infection should be explained. Now if it is a some cyst, local cyst is there, and if it is a aspiration, then verbal consent is okay. But if you are going to drain or do the abscess drainage, then the written consent is. So if we are putting the needle and we are going to aspirate the content, it has a minor and low risk procedure, so verbal consent is more than sufficient. Okay, so small
Mm.
Bartholin's drainage, if we are going to do by aspirating, then, but if it is a abscess drainage, it is a written consent. It is a painful abscess drainage, so bleeding, infection are the risk, and it is a more than minor procedure. Okay,
The
now
breast
coming,
examination, only verbal is okay.
yes, yes, yeah.
Okay.
Then coming to the termination of pregnancy. Below 16 years, the patient can consent if she is competent, and here we have to check the Gillick competence that we have discussed. So below
Yeah.
16 years, Gillick competent, here parental involvement is advisable, not essential. Okay, so below 16 years for Gillick competent, parental involvement is advisable, but it is not essential. So if the patient says that do not involve the parents, then it is okay, we will not involve the parent provided the Gillick competence is there, and there is no father's role cannot override the consent. Okay, so here we have some question for this concept. Yes, doctor, can you please read this?
A 15-year-old girl attends requesting termination of pregnancy. She demonstrates good understanding of the procedure, risk, alternative consequences. She does not want her parents informed. What is single most appropriate next step?
Now here it is a 15
She's
year and
really competent.
yeah,
She understands,
Gillick.
but she doesn't want to inform her parents. So the
Yes, yes,
option, let's see the options, please.
yeah.
E. Encourage parental involvement but respect confidentiality if competent.
Or B.
Inform parents regardless of patient with and D. Patient doesn't want and she is really competent. Then why not E? We should encourage parental involvement but
She
respect.
demonstrates good understanding of procedure, risk, alternatives. So she is Gillick competent. She does not want her parents to be informed.
Yes.
So we have to respect the patient's wishes and we have to proceed with the uh, encourage parental involvement, but respect the confidentiality if competent. Okay.
E, I am saying E. Encourage parental involvement but respect confidentiality if competent.
Here they have given B. Assess the Gillick competence before accepting the consent. So, here actually E is also correct because here indirectly they have given she demonstrates the good understanding of procedure, risk, alternatives, but she understands. But we have to demonstrate that we have to check this. Okay,
But
always
in the
assess.
question, it says that she demonstrates good understanding of all these things. Means it is already proved that she is Gillick competent.
Yes,
So
yes.
why
Actually,
now assess Gillick competence?
yes,
Because
yes.
she is already. So E should
Here
be the better answer.
E should be better answer, but especially in part 3, there is a scenario which is very similar. And here you have to explain the procedure to the patient. The patient understands. Then you have to talk to the patient in a way that and cross check it. What you have informed, ask her to describe. You got it? Then
Yes.
you check the Gillick competence. That is the checking of the Gillick competence. You because we are checking the understanding. You are getting it. The patient is saying okay, but it is a presumed for the adult that whatever we are saying, they are understanding. It is presumed, but we have to check it for the adult. Are you getting it?
Okay.
So this answer is also correct. Assess Gillick competence before accepting the consent. Okay. Then a patient under 16 years may consent independently if she is a Gillick competent, understand the nature and consequences of the treatment. Parental consent is not mandatory if the competence is established. So this establishment of the competence is important. Okay. Then next scenario.
A 14-year-old Gillick competent girl requests termination of pregnancy. She refuses parental involvement but understands the procedure fully. There are no safeguarding issues. What is the single most appropriate management principle? This is also like that, but the age is 14 and they're at
14
worst.
year, but here they have mentioned she is a Gillick competent. That means
Just
competency we
don't
have
have to assess.
established.
Yes, yes.
Okay.
We don't have to assess now. So here proceed. Nee, nee.
Again,
Other
there is,
proceed with termination when consent is obtained. H.
but here again, encourage the parental involvement is also equally good. because
E.
Because she's a 14 years, she's Gillick competent, she refuses parental involvement, but understands. So our job will be to encourage her parental, but respect the confidentiality if she's competent. Okay. Good practice, encourage involvement of the parents and supportive adults. However, confidentiality should generally be maintained if the patient is competent. No safeguarding risk exists. Next.
A 17-year-old woman consents to termination of pregnancy. The biological father contacts the clinic and states he does not agree with the procedure. What is the single most appropriate consent? Response. In this case, I think the father, we can just think.
There is no role for the father.
No role for
Okay.
the father. There was one
So
option. I think it is G. No, not G.
it should be H. Proceed with the termination if
H.
competent consent is
Yes,
obtained. Okay.
let's proceed with termination. Can I see that option? Proceed with termination if competent consent is obtained. No role of
Yeah.
fathers. Yes, sir.
Yeah.
So she's really competent, no need.
Proceed with the termination if the competent consent is obtained. The father has no legal right to uh, prevent termination or cannot override the competent woman's decision. The pregnant woman's consent is the key legal requirement. Okay. So thing is that as far as termination of the pregnancy is concerned, the Gillick competence is very important. So below 16 years can consent if it is a Gillick competent. Gillick competence must understand treatment and consequences. Parental involvement is advisable but not essential. Father's wishes cannot override woman's consent. Confidentiality maintained if competent and safe. Okay. Now coming to the obstetric conditions. Okay. So consent in obstetrics. Okay. When we are talking about the consent in labor, we need to know that there are certain things like the patient is having pain, or if the patient is given some analgesia which may impair the decision making, then we have to be very, very cautious, because in that stage we cannot take the consent. So when the patient when we are explaining the procedure, we have to explain the procedure in between the contractions. Okay. So if the patient is under anesthesia which is impairing the decision making, again this is not an appropriate thing. So if the patient is under the epidural, then it is normal, consent is possible. Okay. Because there is no impairment of the decision making. Timing, explain in between the contractions, that is very important. And antenatal counseling is important for predictable events, because like if there is a prolonged labor, if there is a maternal exhaustion, we may require instrumental delivery, it may be vacuum or forceps, that has to be discussed in the antenatal counseling, so it improves the consent. So even a short discussion about that is going to be sufficient, provided the patient has understood the things and communicated in advance. Okay. So as far as sterilization during the labor is concerned, like along with LSCS, generally it is not allowed. Exception is that prior antenatal counseling and provisional agreement. So the consent we have to discuss at least 2 weeks before the labor. Okay, that much cooling period we have to give to the patient. Okay. Then emergency obstetric procedures, like if it is a urgent cesarean section for cord prolapse or assisted delivery, then verbal consent is more than sufficient. If time permits, then go for written consent. Okay. Then emergency situation, verbal in presence of witness, and we have to document the reasons. However, a competent woman is refusing the particular intervention, then we have to respect, and even if it is a there is a fetal risk, such kind of scenario also they are asking. Okay. If it is a perineal tear, if it is a simple repair, then it is a verbal consent. If it is an extensive repair requiring either general anesthesia or regional anesthesia, go for written consent. Then ultrasound in pregnancy, we have to talk to the patient regarding the purpose. Then consent written is not required. Documentation, we have to must record the discussion, and we have to give the information that the what is the detection rate. Some things may not be detected also. Then screening test. Purpose, early detection in the asymptomatic woman. When we are performing any screening test, we have to talk about the false positive, false negative, and what is going to be the impact, medical, social, or financial, and fully informed consent is required. Then there are certain
Sir, in
legal aspects.
ultrasound
Not
only verbal.
Yeah, yeah. Written is not required.
Okay, yes, sir.
Okay. Then legal aspects, when to seek the legal advice. Okay, so if the patient is lacking the capacity and there is a disagreement, okay, then we have to seek the legal advice. Okay,
Okay.
there are certain controversial procedures like sterilization, then legal input will be required, and advanced directives, if they are not clear, then again the legal advice will be required. So what is the lack of capacity and disagreement? A patient lacks decision making capacity and the family members disagree, or whoever is the parent or the guardian, legal guardian, there is a disagreement with the medical team, then healthcare team disagrees with the relative, or best interests are not clear, then serious treatment decisions are involved, then action is to seek the legal help or the court involvement is needed. Okay, so legal help input are to be taken when there is a disagreement. Okay, there is a lack of capacity and there is a disagreement. However, competent adult can refuse it. I hope you are getting it. But when there is a lack of capacity, they cannot refuse. And the next person, whatever is giving the decision, that is disagreeing with the healthcare team, then you go for legal inputs.
Legal.
Then key legal principle is that no role of the next of the kin in the consent. Doctor must act in the best interest of the patient. Okay. Second is an advanced decision. Okay. Now, when we talk about the advanced decision, this advanced decision must be respected if it is valid, like a refusal of the blood transfusion. Okay. So this advanced decision we need to respect. Then uh, certain things like in patient's record, we are recording certain images, etc. It's a part of the record itself, so no extra consent is required. But if they are to be used for teaching or research purpose, written consent is required. Okay, so whatever the images, maybe ultrasound images or the colposcopy images, if it is a part of the record, no extra consent is required. But if it is for teaching or research purpose, written consent is required. And if there are identified images for any of these purpose, then there has to be explicit consent, including that particular thing should be there. Okay, so avoid personal phones and unsecured sharing, etc. For training, for if the student is present there, explicit consent is required. Okay, specific consent pertaining to that student examining the patient. Okay, then pelvic examination under anesthesia, written consent is required. Okay, for training. Okay, if it is a student and a patient is under anesthesia, that does not mean anyone can examine. If the student is going to examine the patient under anesthesia, then prior written consent is must. Okay, then tissue samples, for histology it is implied, then for research purpose proper consent is required, and for fetal tissue also written consent is required. Now, verbal versus written consent. Whether it is the written consent, always no, not always written consent required. Even in emergency situation, we can go ahead with the verbal consent, provided it is documented. Okay, so key principle is that consent is a process and not just filling the form, and documentation must include the risk, benefits, and alternative. Okay, now failure to take the consent, it is a misconduct by the GM. As far as GMC is concerned, GMC will consider it as a professional misconduct. Okay, as far as law is concerned, it will be assault or the battery. Okay, and there can be regulatory action. Okay, now vaginal examination without the consent, if the vaginal examination is done without the consent, it will amount to the assault, or there may be GMC referral also. Okay, oophorectomy is done without discussion, it is a sort of battery or the professional misconduct. Sterilization without consent is a major legal claim. Failure to discuss material risk is a negligence. Okay, teaching examination under anesthesia without consent is a serious professional misconduct. Then final summary is that what is important: capacity, voluntariness, and adequate information and time to decide. So these are the important things when we take the consent. So for examination point of view, consent is a process, not just a signature. Must include risk, benefits, alternatives, no treatment. Use numerical risk explanation. Never take consent during examination. Always provide time to reflect. Gillick competence is the key concept. Refusal in minors is not absolute. It can be overridden by the parents. Okay. Emergency can override the consent score. Then chaperone is mandatory for pelvic examination. Consent should be specific and it should be documented. If there is unexpected findings, do not proceed without consent. In labor, verbal consent is acceptable. Refusal must respect even in pregnancy. Next of kin, there is no legal authority. Okay, consent is a process and not a signature. Okay, so there are certain SBS, doctor. Now, please read few SBs. Yeah.
A 32-year-old woman is scheduled for laparoscopic cystectomy. Consent is taken on the morning of surgery without prior discussion. What is the most appropriate statement? So, valid if written consent obtained, valid if patient signs form, invalid due to lack of reflection time, valid in all elective cases, valid if witness. So, C is invalid due to lack of reflection time.
Yes, yes, and practically here is a problem with the early recovery guidelines. Okay, because we are admitting the patient on the day of the surgery. But
Same day.
however, there has to be adequate discussion in the pre-operative room as well as in the clinic. Okay, so if this is not there, then
It is
consent
invalid.
must allow time for reflection. That is the cooling off period. Same day consent without prior counseling is inadequate. Okay, next.
During hysterectomy, unexpected endometriosis is found. Surgeon proceeds with extensive excisions without prior consent. Best statement is always acceptable, acceptable if beneficial, only if minor procedure pre-consented, acceptable in all, no need to inform the patient. So be acceptable if beneficial.
No, it should
No,
be only if minor
accept,
procedure pre-consented. Okay,
okay.
because
Only if minor procedure
endometriosis is a
pre-consented.
separate pathology.
Yes, sir.
Unexpected, this it is an unexpected endometriosis. It is not the hysterectomy which is performed for the endometriosis. Okay, this
Okay.
an unexpected endometriosis is found during the hysterectomy. Okay,
Yes, it is.
so
Second pathology.
answer will be only if minor procedure consented. So additional procedure only if pre-consented or emergency.
So it is a second pathology, and we should take a
Yeah.
consent for that also.
Yes.
Wait.
Next.
A woman refuses cesarean section despite fetal distress. She has capacity. Next step, proceed in fetal interest, seek husband consent, respect refusal, court order, proceed under best interest. So it is C, respect the refusal.
Yes, we have to respect refusal. The child, once it is born, then the rights will come. Okay. So
Yes,
before the birth, we
child
have
has
to,
no right.
yeah, yeah. So competent woman's refusal must be respected even if fetus is at risk. Okay. So maternal autonomy. Next.
Which is true regarding risk explanation. Only risk, serious risk discuss, use medical terminology, tailor to patient understanding, numerical data not needed, rare risk can be omitted. So it is B, use a medical terminology.
Which is true regarding risk explanation.
Sorry. Only serious risk, use medical terminology, tailor to patient understanding, numerical data not needed, rare risk.
We should tailor to the
Tailor to
patient.
patient the
We should,
understanding,
yeah.
C.
Risk
What the
must be
patient can
individualized and
understand.
understandable, including serious and material risk and Montgomery's principle. Okay, there is a Montgomery's principle.
Yes,
Next,
only the language which is acceptable or understandable by the patient. In that language, we must tell her.
yeah, next.
Pelvic examination without chaperone documentation. Best statement. Acceptable if patient agrees. Not required in OPD. Mandatory to offer and document. Only for male doctors. Optional. So it is C, mandatory to offer and document.
Yes, it is chaperone must be offered and documented. Next.
A woman withdraws consent during hysteroscopy. What should be done? A. Continue the procedure, stop immediately, sedate and coordinate, seek family opinion, ignore requests. So it is B. Stop immediately.
Immediately stop. Okay, the patient can withdraw consent at any time. So
Yes.
consent is a dynamic. Next.
Yes. Who can take consent for surgery? Only consultant, any doctor, trained person with knowledge, nurse only, junior doctors. So it will be any doctor, trained person with knowledge. Trained
Trained
person with
person with
knowledge. Yes.
knowledge must be
Yes.
appropriately trained and knowledgeable. Okay, delegation of the consent can be done. Okay, but the person should be appropriately
Trained and
trained.
knowledgeable,
Okay.
yes.
Next.
Which is not required for valid consent. Capacity, voluntariness, written form, adequate information, understanding. So, valid consent, written form. Written form, see,
Yes, not always. It need not be written always. No, written consent is
can be
not always
verbal
required.
also, no?
Okay.
Yes.
Next.
Unexpected ectopic pregnancy found during laparoscopy action. Close the abdomen, wait for consent, remove ectopic, see court order, and call the relative. It is remove the ectopic, C should be the
Yes,
answer.
answer is given. Okay. So life-saving emergency proceed under
Even with the
proceed.
consent.
Uh, okay, emergency exception. Next.
Which is correct about minors. A cannot consent, always need parent consent. Gillick complaint can consent, father consent mandatory, court consent always needed. So always need parent consent. Minor age has not been. Minor means how old?
They have not given in this situation. So minor will consider below 16 here.
Gillick component can consent.
Really
C should
competent
be the
can,
answer.
yes. Mature minor can consent. Next.
Consent taken during active labor pain based statement. Always valid, always invalid, may impair capacity, same as normal consent not needed. To see it may impair capacity.
Yes, it will impair the capacity. Pain analgesia may impair the capacity. Next.
Which scenario requires written consent? A. Pap smear, speculum examination, IUCD insertion, BP measurement, abdominal palpation. So it is C. IUCD insertion.
Yes, IUCD insertion. So invasive procedure, written consent is preferred. Even if it is OPD procedure, then also we have to take written consent. Next.
Consent form signed but risk not explained valid. So A. Yes, no, only witness, yes if urgent, yes if standard form. Consent form signed but risk not explained. So the
Is
question
it
says
valid?
that this is
Is
valid
it?
or not. Huh?
Hmm.
So
Is
the risk not explained, so
it is
it is
invalid?
not valid. It is not valid.
Okay, so consent is invalid without informed discussion. Next.
Who can override consent refusal? Doctor, B. Husband, C. Court, nurse, and family. Who can override refusal?
Court can always override the
Court,
decision. No?
C
In
is the
some,
answer. Court
yeah,
can do in some cases. Yes.
only in court in limited cases. The next.
Best example of valid consent. A. Signed form only. B. Verbal agreement only. C. Discussion, understanding, documentation. So it is C. Discussion, understanding, documentation.
Correct. So, so that finishes this particular topic of consent. Thank you.